Tell us how you recognize and manage pneumonitis associated with immune checkpoint inhibitors, and what are the special considerations in patients with lung cancer? Pneumonitis is a rare occurrence with immune checkpoint inhibitors at about 3% of patients across clinical trials. However, there has been some documentation that patients with lung cancer are at higher risk for developing pneumonitis, and this may be due to their altered pulmonary integrity. The time to onset can be anywhere from 9 days to 20 months after start of therapy, with a median onset of 2.8 months. It is noted that there is an increase in toxicity with combination therapy. As I said, there is a higher incidence with patients with lung cancer. It's also been noted across trials that there is a higher incidence in men and former or current smokers, higher than you would see in women or non-smokers. The presentation includes dyspnea, dry cough, wheezing, tachycardia, increased oxygen requirements for patients that are already on supplemental oxygen. Occasionally you may note hypoxia, chest pain or discomfort. Less commonly, a fever may be present. It's important to keep in mind that about a third of patients, however, are asymptomatic or do not note any change, and they are diagnosed when they have their routine restaging imaging. And what was normally seen would be ground glass opacities. The differential diagnosis for the symptoms I've just described may include other medical complications. So in order to complete your diagnosis of pneumonitis, it's important to rule out other potential causes. And those might be infection, pulmonary embolism, pleural effusion, pulmonary fibrosis, sarcoidosis, and even disease progression. Evaluation is a multi-step process. Often the first symptom of a patient having pneumonitis may be an altered oxygen saturation. This is a very easy test that you can do in your office. We suggest obtaining a baseline oxygen saturation on all patients that are starting on immune checkpoint inhibitors. Obtain that oxygen saturation level at rest and have the patient do some ambulation in a hallway so that you do a stress oxygen level. And then repeat that at regular intervals to see if there's any change. Often, this very subtle change in oxygen saturation level is the first indication that a patient may be developing a pneumonitis. Once suspected, a CT scan with high resolution is recommended. And also important to recommend and let the radiologist know that you're looking at not only the potential for pneumonitis on a checkpoint inhibitor, but also to rule out other causes. So dual imaging with and without contrast dye is going to be required. The features that you may see on a CAT scan include ground glass opacities, cryptogenic organizing pneumonia, hypersensitivity patterns, interstitial infiltrates, consolidation, and in some cases, septal inflammation. If an infection is suspected as well, it's important to obtain the infection workup, and that includes sputum specimen and nasal swab for potential viral pathogens. In some cases, the picture on the CAT scan may not be completely clear, and patients may require a bronchoscopy with bronchoalveolar lavage to rule out infection and malignant infiltration. Keep in mind, patients that are receiving checkpoint inhibitors could indeed have two lung diagnoses. They may have a pneumonitis as well as an infiltrating pneumonia, so they may require management for both of those. Pulmonary function tests may be helpful and may demonstrate a restrictive pattern. The risks of not identifying pneumonitis is that they can be life-threatening if they are left unmanaged. The initial stage for management for stage 1 and 2 is going to be to hold the immune checkpoint inhibitor until you have clearance on the CAT scan of the ground glass opacities. Patients may require supportive care of oxygen supplementation and dyspnea management, maybe even pain medication to ease the burden of the breathing. Nebulizer treatments may be helpful with the restrictive pattern that is noted. With more advanced cases, so stage grade 2 or grade 3 or higher, patients are going to require steroids, moderate dose steroids, and that's 1 to 2 milligrams per kilogram per day. If patients are not responsive within the first 24 to 48 hours, increased doses of steroids are recommended. In some cases, patients may be placed on empiric antibiotics if it's thought that there is a risk for infection. If there is refractory pneumonitis, in other words, if the patient is not improving on the dosing of steroid that is used, patient may require additional immunosuppressant therapy, such as infliximab or mycophenolate. For cases of grade 3 and 4 pneumonitis, immunocheckpoint inhibitor therapy is going to be permanently discontinued.